Welcome to the weekly Neurology Deep Dive, produced by Amer Gavanini. Just a reminder, this deep dive is purely for educational purposes. There's no commercial goal here. It's really just a summary of some important findings.
And we always recommend you go back and read the full papers yourselves for all the details.
Absolutely. So today we're taking a closer look at variant TTR amyloidosis. Specifically, we're challenging some long-held ideas about genotype-phenotype associations.
Right, the old thinking that certain variants only cause heart problems or only cause nerve problems.
Exactly. We're focusing on sources that really suggest neurologists need to rethink how they screen patients, especially those with the Val142I variant.
Ah, yes, Val142I, and just for clarity, that's the one formerly known as Val122I. The traditional view was rock solid. This variant, especially common in people of West African heritage, caused TTR amyloid cardiomyopathy, period.
And the flip side was Val50-MET, which used to be called Val30-MET, that was considered the classic cause of TTR amyloid peripheral neuropathy.
We'll be using the current names, Val142I and Val50-MET, throughout.
Good. So the main point we want to get across right at the start, sort of the practical summary for everyone listening.
Is that this neat separation, it's just not accurate anymore.
Precisely. The traditional view is breaking down.
That's the key takeaway. The evidence is mounting, quite convincingly actually, that Val142I, the supposedly cardiac variant, very often presents with clinically relevant TTR amyloid peripheral neuropathy.
This is a really fundamental shift. It means if you are seeing a patient, say, referred for heart failure, and they have this Val142I gene.
You absolutely must look closely for neuropathy. It's not some rare exception anymore. Depending on how thoroughly you assess, it might even be the norm.
Okay, let's unpack that. The traditional view really downplayed nerve involvement in Val142I. How did we get here? Let's look at the data from two key cohorts which show surprising variability.
Yes, we have a UK cohort study from Zhang and colleagues and a US one from Zampino and colleagues. And they paint, well, slightly different pictures of the prevalence and severity.
Let's start with the UK data. They did a retrospective review of 52 individuals with confirmed Val142I. What was the initial presentation?
Clinically, it followed the old pattern mostly. About 90% presented with cardiac issues, only about 10% came in primarily because of neuropathic symptoms.
Okay, so far so traditional. But then they looked closer.
Exactly. Once they did a full workup, clinical exam, neurophysiology, and crucially, skin biopsies if they suspected neuropathy.
Targeted biopsies then, not universal.
Right, targeted based on clinical suspicion. After all that, they confirmed TTR amyloid peripheral neuropathy in about 40% of the total group, 21 out of 52.
40%. Okay, that's already a big jump from the initial 10% presentation. That definitely makes it a major clinical feature, not just a footnote. What kind of neuropathy did they find?
It was a mix. 8 individuals had large fiber axonal neuropathy, mostly sensorimotor, a couple just sensory, and then 13 had small fiber neuropathy.
The severity.
This is key for the UK group. They generally found it to be mild.
How did they measure that?
They used the neuropathy impairment scores, the NIS. The average score was 9.0.
For context, an NIS of 9.0, that reflects pretty mild objective deficits, right? Things like strength, reflexes, sensation, often not causing major disability at that stage.
Correct. And their average Charcot-Marie-Tooth neuropathy score was also low, around 4.8. So the picture from the UK is neuropathy is present in about 40%, but it's generally mild.
Okay, now let's jump across the Atlantic. The U.S. cohort study by Zampino and colleagues, they looked at 31 treatment-naive Val142I patients. What did they find?
Well, their findings were quite striking in comparison. They used a broader definition for peripheral nerve involvement.
How so?
They counted it if there was abnormal neurophysiology or a positive skin biopsy, or even just if the patient was prescribed neuropathic medication, a very comprehensive net.
And using that wider net.
They found evidence of peripheral nerve involvement in about 94% of their patients.
Whoa, wait, 94% compared to 40% in the UK? That's a massive difference.
It is enormous. And it doesn't stop there. Look at the severity. The U.S. cohort's average neuropathy impairment score was 22.
22. Compared to 9 in the UK group, that's more than double the severity score.
Exactly. Double the severity and more than double the reported prevalence.
Okay, we need to understand this discrepancy. 40% versus 94% prevalence, NIS 9 versus NIS 22. Is it just different populations, maybe subtle genetic differences? Or is it really down to how they looked?
The analysis in the papers leans heavily towards assessment methods and potentially referral bias. The U.S. study, crucially, did universal skin biopsies on everyone. They actively looked for small fiber neuropathy.
Whereas the UK group only did biopsies if they already suspected it clinically.
Precisely. So if you don't screen systematically for small fiber neuropathy, which standard nerve conduction studies can miss, you're likely to undercount it significantly.
That makes sense. What about referral bias?
The U.S. group noted their patients were often diagnosed based on cardiac disease first, but then got referred for a full neurological assessment after that diagnosis. The severity difference, though, NIS 9 versus 22, that feels very real functionally.
Right. An NIS of 22 usually means clinically obvious impairment, something affecting daily function, whereas 9 can often be subclinical or a minor nuisance.
Absolutely. So the takeaway isn't that one study is right and the other wrong, perhaps.
Yeah.
It's that Val142-IL neuropathy is definitely present. Its apparent prevalence depends heavily on how hard you look, especially for small fiber involvement, and its clinical severity seems to vary quite a bit between cohorts, but it's clinically significant in many.
That variability is really interesting. Okay, let's broaden the view now using the U.S. study again, because they didn't just look at Val142-IL, they compared it to other variants, right? Late onset Val50-Met and Lu58-His.
Yes, they had 31 Val140-IL patients, 12 late onset Val50-Met, and 13 with Lu50-His. Looking at demographics first, there were some differences in age.
Who presented oldest?
The Val142-IL group, averaging about 73 years at presentation. That was older than the Val50-Met group, who averaged around 65, and the Lu58-His group at about 67.
And what about family history? Did people know they carried the gene? This seems critical for how we find these patients.
Very critical point. For Val142-IL, awareness of the gene before diagnosis was really low, only about 10% knew. Same for late-onset Val50-Met, about 17% awareness.
So for these two common ones, diagnosis mostly relies on clinicians suspecting it, not family screening uncovering it beforehand.
Exactly. It was only the Lu58-His group where family awareness was high, around 69%. So for Val142-IL and late-onset Val50-Met, clinical suspicion is absolutely paramount.
Okay, now comparing the neurological severity again using those NIS scores from the U.S. study. We know Val142-IL averaged 22. How did the others compare?
The difference was stark. Val50-Met averaged an NIS of 61 and Lu58 averaged 60.
60 and 61 compared to 22. Wow.
Yes, profoundly more severe neuropathy in the Val50-Met and Lu58-His groups. This really confirms that while Val142-IL does cause neuropathy, it's generally a milder neurological phenotype compared to these other two classic neuropathic variants.
Milder, okay, but how fast does it get worse? The progression rate is so important when we're thinking about treatment.
That's another key difference. Val142-IL neuropathy progressed much more slowly. The estimate was about 10 neuropathy impairment score points per year.
And the others?
Both Val50-Met and Lu58-IL progressed at about double that rate, roughly 20 NIS points per year.
So progressing at half the speed, that potentially means years more of preserved function for Val142-IL patients compared to the others, which makes catching it early even more crucial, doesn't it?
It really does, because we have treatments now that can slow that progression.
Interestingly, the sources mentioned that even though Val142-IL seemed more sensory on nerve conduction tests, the actual points lost on the NIS score across all three variants were mostly due to loss of strength. Any thoughts on why?
Well, it could reflect how the NIS itself is weighted, perhaps giving more points for motor deficits. It's a useful reminder that the score gives an overall picture, but doesn't capture every nuance of the deficit pattern.
Good point. Okay, let's pivot to the really practical stuff, the red flags. What are the key clinical signs neurologists should be looking for that scream, consider TTR amyloidosis, regardless of the specific variant?
Number one, without a doubt, is carpal tunnel syndrome.
Tell us about the prevalence in the Val142-IL group.
It was practically universal. About 97% of the Val142-IL patients had it, and in about 84%, it was bilateral.
Bilateral carpal tunnel syndrome in almost everyone. But here's the kicker you mentioned earlier, the timing.
This is astonishing. In the Val142-IL group, carpal tunnel symptoms started 7 years or more before the actual TTR amyloidosis diagnosis in about 30% of cases.
7 years. Let that sink in. That's an incredible potential window for early diagnosis. It implies neurologists, hand surgeons, primary care docs. We've potentially been seeing these patients for years for their carpal tunnel, not recognizing the underlying systemic disease.
It makes bilateral, Seemingly idiopathic carpal tunnel syndrome especially requires surgery, a massive red flag demanding further thought about TTR amyloidosis, even if there are no obvious cardiac or other neuropathic symptoms yet.
Okay, so carpal tunnel is huge. What else on examination? You mentioned the skin biopsy findings too.
Right, confirming the pathology. In the U.S. cohort, reduced nerve fiber density at the ankle was found in about 71% of Val-142IL patients, and Congo red staining actually showed amyloid deposits in skin biopsies in about 40% of the Val-142IL patients.
Lower than the other groups?
Yes, lower than Val-50-Met, about 73% positive, and Lu-58 is about 83% positive, which fits with Val-142IL having a generally milder neuropathy and perhaps less amyloid burden in the peripheral nerves. But 40% positivity still reinforces that the nerve deposits are definitely there.
Beyond carpal tunnel, was there another key exam finding?
Yes, the Romberg sign. It was positive surprisingly often, even in patients with milder overall neuropathy scores.
How often?
About 39% of the Val-142IL patients had a positive Romberg. It was higher in the others, about 58% for Val-50-Met and 77% for Lu-58Hes, correlating with their greater severity.
A positive Romberg sign suggests issues with proprioception, right? Could be dorsal root ganglion involvement, maybe even central pathways.
Exactly. So finding unexplained bilateral carpal tunnel syndrome and a positive Romberg sign, that combination should really push TTR amyloidosis way up your differential list.
Okay, we've established Val-142IL definitely has a neurological footprint, often significant. But let's not forget its traditional reputation. We need to talk about the cardiac side, the elephant in the room that maybe overshadowed the neuropathy for so long.
Absolutely. And the data confirms Val-142IL is still, by far, the most cardiac dominant of these three variants.
Yeah.
Cardiac involvement was sky high in the Val-142IL group, about 94%. Compared to about 83% in the late-onset Val-50-Met group, and much lower, only about 31%, in the Lu-58His group. So yes, when you see Val-142IL, you are almost certainly dealing with significant heart involvement.
And the cardiac markers from the U.S. study back this up.
Completely. Val-142IL patients had the thickest interventricular septums, averaging 1.70 centimeters, and their pro-B-type natriuretic peptide levels were extremely high, averaging around 5,900 picograms per milliliter. Classic signs of infiltrative cardiomyopathy.
These are the numbers that grab a cardiologist's attention immediately. You can see how the severe heart failure presentation would dominate the clinical picture.
No question. And it wasn't just the heart muscle. Val-142IL patients also had more signs of systemic issues related to heart failure, worse kidney function, higher rates of needing loop diuretics, about 84% were on them, and more atrial fibrillation, about 39%.
So the presentation is often overwhelming cardiac failure, potentially masking or making the neuropathy seem less important, especially if it's milder initially.
That's likely been a huge factor in why the neuropathy was underappreciated for so long.
Did they look at other systems? What about gastrointestinal involvement? That's common in some TTR types.
Yes, and it showed another clear difference. GI symptoms, things like nausea, feeling full quickly, diarrhea, constipation, were actually rare in the Val-142IL group. Only about 6% reported them.
But common in the others.
Much more so. About 42% of the Val-50-Met patients had GI issues, and about 54% of the Lu-58 patients did. It highlights the systemic but varied nature of this disease across different variants. You need a really thorough review of systems.
Okay, let's bring all these threads together. We need a clear, actionable summary for neurologists listening. What's the absolute must-know point from this deep dive?
The core message, the thing to remember, is that Val-142IL causes TTR amyloid peripheral neuropathy. It's not just cardiac. The prevalence is substantial, maybe 40%, maybe up to 94%, depending on how hard you look.
And while it's typically milder and progresses more slowly than the neuropathy seen in Val-50-Met or Lu-58His,
It's still clinically relevant, progressive, and importantly, potentially treatable.
so the clinical implication seems unavoidable. Every single patient diagnosed with Val-142IL TTR amyloidosis needs a proper neurological evaluation, looking specifically for signs of peripheral neuropathy, including small fiber neuropathy.
Yes, because finding it early opens the door to disease-modifying therapies that can slow down that 10-point per year NIS progression we talked about.
And the key screening points to remember in any patient, even before a genetic diagnosis.
Bilateral carpal tunnel syndrome, especially if it's long-standing or required surgery. That's number one. And number two, check for a positive Romberg sign. That combination is highly suspicious.
Even if the main complaint seems purely cardiac initially.
Especially then, perhaps. Don't let the severe cardiac picture make you overlook the nerves.
Which brings us to our final thought for you, the listener, to chew on. We know the Val-142I neuropathy can predate the obvious cardiac symptoms by years, sometimes many years, as shown by the carpal tunnel data. But it's often milder initially.
So the question becomes,
How can we, as neurologists, get better at catching these patients early? Maybe even before they land in cardiology. How do we incorporate screening for things like bilateral carpal tunnel or subtle balance issues into our routine practice to identify these TTR amyloidosis patients when treatment might be most effective?
that's the challenge, isn't it? Integrating this systemic disease awareness into neurology clinics proactively.
Definitely something to think about. Thank you for joining us for this weekly neurology deep dive. We hope this discussion helps you in your clinical practice.